I want to start, actually, with an incredible thank you to Kathrin Troppmann, who not only is going to lead us through this event and is one of our distinguished, I'm trying to find a different word than senior.
You can say senior.
I can put it in perspective.
Faculty members. Mid-career.
Mid-career.
I
Okay,
like that.
thank you. Thank you.
And who, in addition, has done just a yeoman's amount of work to get our celebratory gala, which is next week. For our faculty and our alumni and residents, if anyone has not received their invitation or has questions about it, please feel free to reach out to me. And we are looking forward to beginning a season of celebration and recruiting our new resident class of interns. So all of that starts this Thursday and Friday. I know the residents got together last week to kind of practice, so look forward to all of that. So without further ado, I really want to turn the morning over to Kathrin, and thank you again.
Thank you, Dr. Farmer. So Dr. Farmer asked me to organize events related to the 50th, as just mentioned. I thought that this was a timely opportunity to gather and summarize the history of our department over the past 50 years. The challenge was not that there was not a lot of history documented. Therefore, I thought that the best way to obtain the history is to ask the people that were critical contributors to it, the chairs and the professor emeriti. They are best able to portray the history in their own words. I have no financial disclosures. I do have some disclosures in that I'm a new member, proud member of the Quarter Century Club. We had our first dinner last Thursday, and I was inducted. And this was my congratulatory letter. I have lived 25 of the 50 years, so half of the years of our Department of Surgery, I have been here at UC Davis. I've worked with 4 of our 5 distinguished chairs, and I receive AARP magazines. So for every great epic, there's a backstory. So before our 50 years here at UC Davis, in 1849, miners came from everywhere in America to find the American dream. With them came disease and epidemics as well. Those patients needed physicians, so there were doctors that also arrived, some quacks and some imposters, charging exorbitant fees. They were living in tents, most of these miners, in downtown Sacramento and along the river. The Sacramento City Council recommended that a hospital be built in 1850. And finally, in 1852, that hospital was established in downtown. Flooding was common at the time. In 1871, the hospital was built in its present location on Stockton Boulevard. But it burned down in 1876, only to be rebuilt again in 1879. In 1928, the hospital was rebuilt again with a north-south wing that still remains today in part. And finally, in 1966, Sacramento County Hospital became affiliated with UC Davis University and became a teaching hospital. This is a depiction of the 1879 hospital. You can see we have carriages bringing our patients and our visitors to the front entrance, which is presently between the north-south wing of the hospital. In 1955, it looks quite different. We see still the nursing dormitory, or they called it the nursing home, which is now the house staff building where we still have our transplant service housed, built in 1916. In 1928, the pavilion-style wings were established, and then in 1955, the north-south tower with those famous ramps was built. Our property used to be the fairgrounds of Sacramento, and you can still see up in the top corner, over there, where we're now sitting, the Sacramento County Medical Center. We are approximately at number 13, just below the water tower that still stands today. In 1968, the School of Medicine was opened, and this dean, Dr. John Tupper, or Tupp, as you'll hear in one of the videos, was our first dean, with a class of 48 students. The ownership changed, and research mission in 2000 was expanded significantly, and the Mind Institute opened. In 2006, the UC Davis School of Medicine moved from Davis to Sacramento, relatively recent. This is a relatively modern picture. You can see the north-south wing on the lower left corner, expanded in 55, the east wing in 64, the University Tower in 82, Davis Tower in 97, the Cancer Center, 2001, expanded in 2012, and most recently our pavilion. So every epic has protagonists, and these are our protagonists in our epic, our five chairmen, 4 still living. We questioned our UC Davis General Surgery alumni regarding the factors that affected their residency program selection. This was in 2000. Both men and women listed that the chairman was the most strong influencer of their residency choice. What I'd like to do now is take you through our 5 chairmen and women, to let them tell you a little bit in their own words of our epic story.
Academia must be part of the practice of medicine, not apart from it. My goal after about 3 years in academia was someday to have a department, chair a department of my department of surgery of my own.
Sure.
And I felt that the experience I would have dealing with departments from an administrative standpoint would put me in good stead were I ever to have a department. So I did that. And then after, it was 4 years, 1964, I went to Bill Hubbard, whom I admired greatly, the dean, and asked him to accept my resignation because I had just been appointed chief of one of the 2 major surgical services at Ann Arbor. I had gotten a large NIH research grant. My research was flourishing, and I knew one other thing. I did not want to be a dean. I did not want to be a dean. No, I still wanted to be a departmental chair. And he said, "Earl, that place is a sleeping giant." And he told me about the
You're talking about salesmanship already.
Oh yeah, oh yeah, oh yeah. He said they've got the radiobiology laboratory. It's got the largest geographic area in the country for its campus. It's got the only national primate center. The School of Veterinary Medicine has as its mission to develop animal models of human disease, and just went on, and he said that Chancellor Marak was one of the most fascinating individuals I've ever met. And he concluded by saying that he is going back for a second visit in November, and would I accompany him as a candidate for the chairmanship of surgery. The next day, we went into the hospital, visited with hospital administration.
Now, this is the county hospital.
County hospital in Sacramento, thank you, Bob, to discuss the feasibility of an affiliation agreement. I met with a surgeon who had just come there a few months before in July, who was full-time, and pointed out to him whether I came or not, if this hospital was affiliated, they should have a surgical residency program, and asked him to begin accumulating statistics, because I was getting kind of impressed with the place, as a matter of fact. And at that time, the state of California had the greatest reputation of any state in the union in their support of higher education. To have the opportunity to come out and start a medical school in this environment, starting it from scratch, where you weren't saddled with biases and so forth. I love traditions, but some of them can stop you rather than help you. John put his starting date February of '66. Mine was July 1st of '66. I worked on the proposal, submitted an application, and lo and behold, in June of 1966, I received a letter from the Liaison Committee on Graduate Medical Education stating that my residency program had been approved as of July 1st, the day I was arriving, and we still didn't have a hospital affiliation. No, John, I do not want to become a dean. I have no desire for it. And gave him a million other excuses. And finally, after much persuasion, I agreed to accept it on a temporary basis. I had the feeling, here I am, chief of surgery, chairman of a division with 10 departments in it, associate dean of a school of medicine that has no buildings, no students,
No people.
no faculty, no curriculum, no approval to even admit students. And it was kind of a discouraging thought, and I too wondered what I was going to do. But that soon became clear. We went to work immediately on the organization of the School of Medicine. Go ahead, Bob.
I was going to say there was talk. I wondered why they didn't think about putting a hospital in Davis, and I know that the concentration of people in Sacramento would be an attractive thing.
Well, we needed something immediately. Emil said, remember, quickly, like immediately.
Okay.
And so we needed a facility immediately, and subsequently in our long-range plan that we developed, we did program can you believe this, 1,000-bed hospital on campus,
Really?
adjacent to where the Tupper Hall is now, with bed on one side and human medicine on the other. But we went to work on the hospital affiliation. That was approved in August of 1966. Then the most important thing that we had to do was to recruit faculty. There was no way we could do anything without having a core group of competent medical educators that were going to be here for the long haul to come up and help and devise this thing. So Tup and I were recruiting time after time. We were out of town. In fact, we probably spent as much time out of town as we did in those early years. And I attended every national surgical meeting where I would fly the banner for Davis that we were in business. At that time, on those occasions, I would interview potential recruits, and I'd solicit information of other recruits or other individuals who might be available. John did the same thing, and we'd return to Davis, change our laundry, and take off again. At the end of that year, we had 7 full-time faculty persons, ultimately referred to as the Lucky 7.
Aren't you pleased with the recognition that the medical school now has nationally and internationally even?
Bob, I'll tell you, I can't tell you how pleased I am, and I get a thrill every time I drive to that hospital in Sacramento and see how things are going and hear the comments of colleagues from other schools and the recognition that our school as a whole has received, and particularly, and from a personal standpoint, the recognition the surgical programs.
You and I both went to a meeting recently where they talked about the new buildings that they're building on the campus in Sacramento. That is, there are towers being built that I'd never heard of before, and they're putting in new library facilities, as I remember, are going in over there. If one were to think back to what that campus looked like when you and I first came here and go to see it now, there's a whole spectrum of large and new and functional buildings that comprise that campus. Are you able to keep up with all these changes that are going on?
Do you know why they're there?
No.
Because when we came to Davis and took over the county hospital, behind us was 50 acres of land called the California State Fairgrounds.
I see.
And when they moved to Cal Expo, we petitioned Emil and said, Emil, we've got to buy that land because it's right adjacent to the hospital and someday we're going to need it. Well, even Emil kind of dragged his feet on that. But finally, he went to Berkeley, and Emil was as persuasive as Tup. Those were two
They had a lot in common,
yeah,
didn't
they
not?
sure did. And he convinced the university to purchase, I believe it was 30 acres of that land. And then when the university, or in the county, seeing what we did, they decided to purchase 15, half the amount. And then when we took over the county hospital from the county, lock, stock, and barrel.
So we have 45 acres.
We've
now.
got 45 acres for expansion in a metropolitan area that no other medical school in the country could boast, and that was because of the agitation that Tupp and I made, and we did that on the basis of, you know what happened in Ann Arbor. You couldn't build one unless you tore one down. We were all out of land.
Yes.
So we still have some we can use.
Okay, I'd like to proceed to William Blaisdell. Dr. Wisner, I see you have arrived. Can you please come and take your seat of honor? Told you so. So Dr. Blaisdell, chairman from 78 to 95, our second chairman.
Dr. Blaisdell, what motivated you to move to UC Davis to take over the helm of the UC Davis Department of Surgery from Dr. Wolfman in 1978?
UC Davis had hardly been used yet, in my opinion, so it would look like a challenge that I might enjoy.
What do you consider to be your greatest accomplishments at the UC Davis Medical Center and School of Medicine?
Probably putting our Department of Surgery in the national arena. Nobody had ever heard of it before, and I think we became nationally recognized as a result of our faculty and our productivity.
What do you consider to be your and your department's most significant contribution to the field of surgery?
Well, we were involved early in critical care, and thanks to Jim Holcroft's recruitment, we established new changes in critical care, in trauma or surgery, and stimulated, I'm sure, critical care among our medical specialties. And we had a number of innovative things in that period. Critical care was just emerging as a separate entity and a separate specialty. So I have no question that that introduction markedly upgraded the care of patients.
You were responsible for developing trauma systems. Can you describe how that came to be during your time at UC Davis?
When I went to Davis, the County Medical Society was aware of all this turmoil, and everybody was taking trauma at that time and were concerned and invited me to come and talk to them about it. And I said, about that time we were being referred, good substantial part of the cases now in the Sacramento area, and let's do our own review quietly and see what we've got. Well, we found out that half the cases that were in the coroner's series came to UC Davis, again with no preventable deaths essentially, and of the other half of cases going to the community, about half had preventable death. And they said, oh, this is terrible, we can't say anything about this. And I said, wait a minute, we had it up. It only comes out to 14 preventable deaths. That's better than any other community has had when they've done their review. Orange County, which prides itself on its hospitals, had 30% deaths. We only have 14. Let's write an article and say we are better than Orange County and all the other counties, but we don't find that acceptable, and we're going to develop trauma centers. Until that happens, we're going to send our cases to UC Davis. So that ended up not only with all the cases being seen by all the private hospitals in the region, but all the hospitals in Northern California started sending us cases. And so we went over the course of a year or two from, 100,000, modest number of cases to the largest trauma program in the United States. And that's what pushed the hospital and, of course, antagonized all our other services because we were flooded with all these emergencies that came in. And they came in by helicopter. We didn't own the helicopter initially. That was a police helicopter. And brought on all this stuff. So that was the initiation of our trauma program.
After a successful career as chairman in the Department of Surgery at UC Davis, what motivated you to develop the inpatient services at the VA hospital, including a surgical team?
Well, I had resigned as chairman of surgery, and I thought the changes going on that we needed some new blood, and so I kind of resigned my position and ended up doing vascular surgery and emergency surgery. No one wanted emergency surgery, so I had a year or two in which I supervised all the emergencies coming out of the emergency room. And all of a sudden, I had a chance to help develop a new medical center in Sacramento. And I had been lobbying for moving the VA from Martinez to the Sacramento campus for most of my tenure at UC Davis. So getting the VA up and running was extremely important because I recognized the VA was an optimal teaching environment for medical students. So that looked to me like another change in my career that would be interesting and stimulating.
You are a pioneer in promoting women in surgery and were recently selected as the recipient of the Association of Women Surgeons Honorary Member Award. What inspired you to promote and practice the inclusion of women in surgery?
No question about it, it's Muriel Steele. Muriel was a colleague in residency with me at Stanford, and she was a couple of years behind. She did not finish her residency at Stanford. Stanford had moved to Palo Alto, and the new chief of surgery refused to have a woman in his program. And so a year short of completion of her training, she was turned loose. And her former chairman of surgery at Stanford, named Victor Richards, arranged a special residency for her so she could complete her boards. So she went out into practice, and she recognized that women surgeons were uncommon, but there were now a number of women in internal medicine. And she thought that would be a source of her practice. So she went around and interviewed all the women that she knew in internal medicine. They said, "Oh, gee, we like you, Muriel, but I'm afraid we can't refer to you." Why not? Because our patients associate surgeons with men. And so she struggled and managed to cover other practices for private surgeons. And at San Francisco General, when I arrived there, we needed a head of outpatient surgery. There was a salary available. And I asked Muriel if she might be interested, and said she was. And so we recruited her on that citywide salary. Now, at that time, medical department was not at all interested in outpatient care. All their practice had been inpatient care because the patients had gone to clinics at UCSF or at Stanford, and the internists at San Francisco General were spared clinic practice. So they weren't interested in clinics at all. Muriel took over and arranged medical clinics and surgical clinics and remained chief overall of clinic services during all of her tenure. But as I recruited more and more surgical staff, it turned out that she was the one I could always rely on to pick up every loose end. And as all of us became more and more academically involved, George Sheldon, Don Trunke, Frank Lewis, all became big names in American surgery. They often were away and or missed their outpatient coverage. And she would ride everybody, and she would cross-cover for people and pick up everything that kept us solvent. So she was kind of the key, and I made her assistant chief of surgery. And that gave me the knowledge that a woman could outwork all the rest of us. And so I had no question that women were capable of working or outworking men. And so when I went to Davis, as we were selecting residents, as you looked at the qualifications, about every other applicant was with qualifications were women, but they weren't being matched at the same degree. So goodness, well, we'll match them as they deserve to be matched. And as a result, we ended up with more women in our programs, whereas everybody else was neglecting them. And so that was kind of the key to developing an outstanding program, is to just take the women at their face value. If they were good, we took them. Nobody else was at that time.
Dr. Blaisdell just celebrated his 91st birthday. Next we have Dr. Goodnight, who took quite a bit of convincing to consider the chairmanship job, or I would actually say begging, since I was around to help beg, because we had valued him significantly as a mentor in our department.
Dr. Troppmann, thank you. I'm going to indulge myself in a couple of thoughts as we get started. I think it's important for everyone to know, who's contemporary, that this department and this institution has a very good history and a very solid foundation. I think it takes a very long time to build programs. The path to success, however you define success, is rarely a straight one. I think it's important we all remember to do the best we're doing at the time we're doing it. I recall a talk by Dr. Judah Folkman, the great pediatric surgeon and vascular scientist. He was describing his career, which was illustrious. But he said, when you're going forward, when you're driving in the dark, you can only see as far as your headlights. In retrospect, when you look at a piece of history or a career, it can look like a very natural, ordered progression. But going forward, when you're driving in the dark, you can only see as far as your headlights.
What motivated you to move to the UC Davis Department of Surgery to take over the leadership of surgical oncology?
When I was a chief resident at the University of Utah in 1976, 3,000 years ago, F. William Blaisdell, Dr. Blaisdell, Bill as we were privileged to call him, came to lecture. He was a riveting presence. The excitement when he was describing their activities, managing trauma, the war zone at San Francisco General, the excitement was palpable. They were organized to manage trauma in a way only our military is organized in wartime. 4 years later, when I finished my surgical oncology fellowship at UCLA and was finishing up things there, I needed a job and I wanted an academic career. Dr. Blaisdell had moved at that point to become chair of the department here, and he needed a surgical oncologist. His charisma was a huge draw, and I was to be the only surgical oncologist in Sacramento with an incredible opportunity to build. Bill himself was actually a bit penurious, and he was offering me a lot less money to work here than at UCLA. My boss there, who was actually a protege of Blaisdell, said, "Don't take the job." I came anyway for all the reasons I said. There is the other reason. My wife found a house in Davis that she loved and she wanted out of LA. She said, "Take the job." We still live in that house.
Please describe your early days in our department.
When I arrived at UC Davis in 1980, I found that our surgery clinic was in a trailer out back where the PSSB is now. Our blue service was also known as the Hickey service. All the good cases went to trauma and GI. He and I looked at each other and said, let's make this into something besides the Hickey service, and we did. When I arrived, Jim Holcroft and I quickly became friends and have remained so through retirement. As acerbic as Jim can be, he was always a source of enormous support, wisdom, wise advice. Good man. Driving to work in those days, I would look and I would say, well, don't look at it as it is now, try to visualize what it could be in 10 years. In 1990, 10 years later, we had far surpassed those early musings. The cancer center was about to open. I had wonderful partners in oncology. We had a new hospital and a new tower was ready to be built. UC Davis Medical Center was on a very strong upward trajectory. This development had been heavily financed by money earned from our trauma service. That's a whole nother story.
Can you describe what fostered the extraordinary growth in the Department of Surgery during your tenure and any challenges that you encountered?
Sacramento was growing. Actually, from 1991 through the early 2000s, the growth rate was 50%, nearly double that of LA and San Francisco Bay Area. Trauma demand was exploding, as was the demand for our other services. Minimally invasive surgery was no longer a novelty. The public was demanding it. I spent all the resources I could, that is the money, to recruit or buy surgeons we needed. We needed the depth, as we said. And there was never enough OR clinic space, never enough as I said, clinic space, never enough money, but then do you ever have enough money? Regarding surgical education, we wanted to play in the big leagues. We wanted to compete right at the top. A substantial key to our growth future was the quality of our trainees. Working with Felix Battistella, wonderful man, as the education chief, later trauma chief, and Lynette Scherer following the same path. We worked together, working very hard to recruit residents. It was a great joy, and it paid off. We had increasing success in the quality of our resident recruits. Many, 22 by my count, there's probably more, joined our faculty. They've become our current leaders, contributed enormously to the department's success.
Can you describe the origin and development of the Cancer Center under your leadership?
The dean at that time, Dean Hibbert Williams, hospital director Frank Loge, and myself, in the bravado of no place to go but up, said, let's build a world-class cancer center. I thought at the time, I said, gosh, if this takes 8 or 9 years to do, I'm out, because I've got other things I've got to do. Well, 9 years later, in 1991, we opened the Cancer Center, and I was still very much involved as the director. In 2002, under Ralph DeVere White's leadership, the Cancer Center became an NCI designated cancer center, and again under Ralph's leadership in 2012, it became an NCI comprehensive cancer center, one of 54 in the nation.
What inspired you to become chairman of the Department of Surgery at UC Davis?
Well, you'll have to take this at face value, but I actually never planned on being chair of surgery, never sought to be chair of surgery. My life been filled with wonderful serendipity. I was doing fine as cancer center director and a busy surgical oncologist. When Dr. Blaisdell stepped down in 1994, I was actually the person politically and administratively most palatable to the dean and the hospital director to be the acting chair. So I became acting chair. But in 1995, at that point I declared I am not a candidate for the permanent position. What ensued at that point was a year-long national search to find a chair of surgery, and it failed. Probably not enough money offered. At that point, the hospital director and the dean offered me the permanent position. I thought, gosh, I'm not sure I have the national stature or the academic credentials to be chair. Dr. Blaisdell had been a dominant presence in our lives, father figure, mentor, and so forth. I wasn't sure that everyone would, I thought they might all leave and that I wouldn't be able to recruit. And I also knew that Dean Lazarus at the time wanted a cancer center director with greater research credentials. So why did you take the position? Well, I thought at a very exciting time in the development of the institution, I would probably be pushed into the backwaters, and I didn't want that. So it was moxie, determination to try to make a go of it. I did have good support, good friends. I had actually the support of the dean. He was an odd duck. He beat me up all the time, but he became a wonderful supporter and mentor. Hospital director was very supportive. We'd spent 14 years trying to put the cancer center together. Associate Dean Jim Castles, who was a very formidable man, never pulled any punches, but he taught me to be chair. He was great support. Don Trunke, the chair and professor at Oregon Health Sciences University, himself a protege of Blaisdell, paid me a backhanded compliment years later. He looked at me, he said, Jim, he said, I thought sure the department would fall apart after Blaisdell stepped down. He said, damn if it didn't grow and develop.
What did you most enjoy about your role as chairman?
Well, I will say that that job, being chair, was the most satisfying role in my career, truly. And what I enjoyed the most were the people I met, whether it was multiple recruits for residents or the national and international surgical leaders, people I never would have met otherwise. It was exciting. This plus the careers of so many residents and faculty that I had an opportunity to participate in and watch the development. It was a wonderful development. It was great working with the other chairs and with the institutional leaders at the time. They were challenging people, of course, but it was more than, it was overwhelmed by the pervasive, lovely experiences I had as chair.
Can you describe for us the scene of the Department of Surgery halfway into your chairmanship years at the turn of the millennium?
Well, I'll try to describe things in the early 2000s. We were blessed with many strengths. We had nationally prominent programs in trauma, burns. Tom Stevenson, the chair of plastic surgery, was on the American board. Our regional presence in transplant surgery, vascular surgery, oncology, GI, bariatric service, all very strong. We were growing minimally invasive surgery. We had a promising developing program in pediatric cardiac surgery, endovascular surgery, robotic surgery. Graduate training program was strong. We had a new VA hospital, wonderful relationship with the Shriners Hospital. Our faculty were relatively young, and we were beginning to have some selected success in research.
What do you consider to be your greatest accomplishment at the UC Davis Medical Center as chair of surgery?
That's pretty easy. It was the great people I recruited or helped recruit. They put down roots, rolled up their sleeves, grew programs, took leadership positions, and built the department into a powerhouse. The work produced a steep upward trajectory for UC Davis School of Medicine and the Medical Center. The work and creativity and success is theirs. Mine was a supporting role, of which I'm very proud. And I do believe I had a strong hand in shaping this department as it exists today. If people carry on and do well with things you've started, then you can feel validated for what you've done. The number of these recruitments to the faculty, actually, if you include the residents who joined the faculty, numbered nearly 50. And of course, then there are more that came after me. All were important. I'm extremely proud of all of them. I will mention a few. There was my partner for nearly 30 years, Phil Schneider, that came in 1982, wonderful man. Rick Bold came in 1998 to expand our academic horizons in oncology. Dave Greenhall, of course, coming in 1996, and followed by Tina Palmieri in 1998 to build the burn program into what it is. Niles Young, recruited in 2001 to rebuild our cardiac surgery program. Gary Raff in 2003 to create a pediatric cardiac surgery program. Nin Nguyen in 1998, and then followed by Muhammad Ali in 2002 for their expertise in development of minimally invasive surgery. Scott Hundahl in 2002 to be the chief of surgery at the new Sacramento VA Hospital. Bill Pevick in 1994 and David Dawson in 2002 to basically recreate vascular surgery. David Cook in 2008 for his expertise in development in thoracic surgery. Robert Cantor, 2007, to take and expand my practice in surgical oncology. Joe Galante in 2007 for all the good things that Joe does. Christoph Troppmann in 2000 to help Rick Perez and John McVicker help build transplant surgery. And so I'll take partial credit for recruiting Diana Farmer to lead this department.
You continued the UC Davis Surgery Department practice of recruiting and promoting women in surgery. What experiences inspired this practice?
I'll indulge myself. I'll paraphrase George Mallory, the famous mountain climber, because they were there. Talented people looking for training positions and jobs. Not recruiting women would be to miss a key part of the workforce and an opportunity to add talent. In addition, we'd had very good support with women in the program. People that we'd recruited in the 1980s, Patty Bishop, Lynette Scherer, Karen Fogelberg, Virginia Joyce, oh yes, and a woman named Kathrin Meyer, then Heidi Murley, to mention a few that were recruited in that time. They taught me early on the gene for raw enthusiasm in performing surgery is not on the Y chromosome.
So the next chair is Dr. Wisner, who very aptly carried our program forward.
You are a UC Davis born and raised. First you were an undergraduate, then UC Davis Medical School, resident, director of trauma, interim chair, and then the associate dean for clinical affairs and the director of the practice management board. Can you please describe your impression of how the university has grown over the years that you have been here?
The place has gotten a lot bigger. Well, you know that. You've been here for a while. It's gotten a whole lot bigger and better. I think the quality of the care that gets delivered, both by the Department of Surgery and everybody else, is better than it used to be. The number of things that we do, the level of expertise is better. So those are all good. Those are all good, great things. I think we've certainly evolved from being pretty much a county hospital to being a legitimate referral center as well as a county hospital, which is unusual in the United States. The downside of all of that is that it's a lot less personal than it used to be. Again, you could relate to that because you've been here for a long time, Kathrin, but it used to be, when it was a lot smaller, it was a lot more personal and you knew everybody. And that's not true now. Even if you've been here a long time, there are a whole bunch of people that you don't know. And I kind of miss that.
Please describe your early days in our Department of Surgery.
as an intern, I kind of fell under the spell, well, really as a student, I kind of fell under the spell of Bill Blaisdell, who was, as you know, one of the chairs the second chair of the department.
Can you describe the growth of the surgery department under your leadership?
I was chair for 3.5 years and was an interim chair between Jim Goodnight and Diana Farmer. So we did add a number of faculty members. Our finances were good. Our residency classes were great. Sounds like I'm self-promoting, but actually most of that wasn't due to me. It was due to the underpinnings of the department, and I just kind of kept it going for 3 to 4 years.
What do you consider to be your greatest accomplishments at the UC Davis Medical Center and School of Medicine?
It was a long period of time without a definite plan about who was going to be chair, how we were going to do that. So I'm proud of that. I don't think anybody left, faculty-wise. I don't think anybody left while I was chair. As I mentioned, our finances were good, and it's not all about money, but at least we didn't go broke. Our residency classes, I think, were great. I think the people that we picked during those 3 or 4 years, I'm really, really proud of those folks, not just because they're great surgeons, but they're really, really good people, and I'm very, very proud of that. We set up, one of the things I wanted to do, it's a relatively small thing, but big for me, is we set up a memorial lectureship for Felix Battistella while I was chair. And then I turned it over to another really good chair.
What were your biggest challenges or obstacles in nurturing the continued growth of the Department of Surgery?
Pretty straightforward county hospital to a more legitimate referral center without losing the identity of the county hospital, which I actually think is important. So it's been trying to get away from the county hospital mindset without losing that ethos of being a county hospital. And that's been a delicate balance. And then I think something that people talk about UC Davis all the time is I think just innately, I don't know where it comes from, but I think innately we don't tend to crow about ourselves very much. I think I'm kind of like that, and a lot of the people who have worked here have been kind of like that, which has its good side and its bad side, right? I'm actually kind of proud of the fact that we don't make a big deal out of how good we are, but we're really, really good at some things, and we've just never beat our chest about it. I'm listing that as an obstacle to overcome, but at the same time I'm realizing I'm kind of proud of that. So it's both things.
During your time at UC Davis, what do you consider to be the department's most significant contribution to the field of surgery?
That one's easy. That's the people that we've trained. Because anybody can do big operations, and we've gotten better at that, and we've developed a more full service Department of Surgery, all of which is great. But the enduring legacy is really all the people that have been trained. And that goes back to Blaisdell. And Goodnight continued it, and I continued it in my small fashion, and Diana's continued it. It's really, I remember Bill saying that what he wanted to produce in trainees were people who would go to wherever they were going to practice. It might be a small community, it might be a big academic institution, and be leaders in that local environment. And I think he was really successful with that, and I think subsequent chairs have been successful with that too. And that's really, I think, what sets UC Davis apart, the Department of Surgery apart.
What are the principles or values that have guided your care of patients, and how have you implemented or practiced them?
You know, I'm just going to steal from Blaisdell again. One of the things I remember about Bill that I don't think I recognized fully at the time was that he was a patient-based care guy before that was part of the lingo. And he did it in a kind of a different way. He did it in the structure. He didn't change the structure to be more patient-centered, but everything we did was all about delivering care to the patients. And I actually think that's the most important thing. It's so easy to forget why we do what we do. I mean, we're not lawyers, we're not businessmen, we're not here just to make money, we're not here to just run a business. We're actually here to do something good for somebody. And it's great if you can do something good for big groups of people, but what it really comes down to is that individual person. And that's another thing I really admired about Jim Goodnight too. Jim was really that way. And so the two people who influenced me the most, I'm just stealing from them. I think that's the most important thing.
And last but not least, our present chairwoman, Dr. Farmer.
What motivated you to move to the UC Davis Department of Surgery from UCSF to take over the leadership as chairwoman?
3 things that motivated me. First, I saw many patients in my practice in San Francisco who were from this region, and I thought, well, that's peculiar. Why are there so many patients that I'm seeing here in San Francisco? And secondly, my research was almost entirely focused here at UC Davis for a decade before I came here, leveraging all the great assets of the #1 veterinary school in the country. Davis had great opportunities for research development. In fact, most people don't know, but almost all of the research that led to the development of fetal surgery, even 30 years ago, was done here in conjunction with the vet school at UC Davis and the animal facilities. So I was driving up from San Francisco to Davis 3 times a week often, and I started to think that this drive was getting a little out of hand. And the third thing that motivated me was just the leadership opportunity to see if I could take some of the skills that I had acquired in the big fancy city university to leverage it in service of the patients in this region and to build on the great legacy of Dr. Wolfman, Dr. Blaisdell, and Dr. Goodnight to take the department to its next level of development.
Please describe your early days in our department.
My early days were spent, I think, listening and just getting to know the department. And I was so impressed to find such great commitment to education. I think that's one of the things that struck me the most when I first came here. The focus on education by all of the faculty for both students and residents. And the pockets of excellence that were here in many places. What I was struck with was that no one knew about it. Davis had, and still I think does have, a very endearing sort of humility characteristic. But sometimes it doesn't help us when we're trying to get the message out for our patients. But those were some of the early observations I had about the department. It was a young department, less than 50 years old, and really, sometimes I think of it as a startup job.
What were your biggest challenges or obstacles in growing our department?
I'd say the challenges in making any change is always culture. There's a great culture and an important culture of the general surgeon, and I still think there's a role for the general surgeon who has a broad practice in many areas. We try to highlight that and enhance that through the development of our acute care surgery program. But at the same time, the culture of specialty care was a bit of a new approach for the department. And anytime there's change, you have to change culture. I also think enhancing the culture of investigation and really having, in addition to education, having inquiry and research be a part of our DNA and a part of everything we do.
What did you enjoy most about your role as chairwoman?
My favorite thing is my role as chairwoman is faculty development. I really like that part of my job the most. And in fact, if that part weren't here, I think sometimes some of the other things wouldn't make the balance come out right. But developing the faculty, seeing the young faculty grow, seeing them find their areas of special interest and figuring out how to allow them to blossom in that, whether that's education, whether that's research, whether that's a clinical niche, that's what's really been fun.
With your research experience, how have you advanced the research mission at UC Davis?
Trying to bring that joy of discovery into the department, trying to inculcate that in all of our faculty, all of our residents, and then helping to develop an infrastructure to make that easier for people has been one of the ways I've wanted to bring my research experience to others. I personally think it's part of our moral responsibility as an academic medical center to always be asking those questions. Can we do it better?
What do you consider to be your greatest accomplishments to date here at the UC Davis Medical Center and the School of Medicine?
Particularly proud moment for me was when our newly recruited chief of pediatric surgery, Dr. Shin Hiroshi, who actually started his surgical career here at UC Davis, came back to UC Davis and did our first fetal surgery operation here. I think people thought it couldn't be done here. And it just goes to show there's nothing that can't be done here at UC Davis. And I think that might have been my proudest moment to date. I'm hoping there are more to come.
What award are you most proud of?
My greatest award came recently when I got an invitation to go to a graduation ceremony at West Point of a patient I took care of when she was 3 months old. That was 21 years ago, and one of the great privileges of being a pediatric surgeon.
Do you have advice for medical students regarding the practice of medicine?
I think medicine remains one of the most rewarding careers that a person can undertake. You have intellectual stimulation, you have a tremendous family of peers and colleagues that you work with, and the privilege of taking care of patients in some of their time of greatest need is a true honor and a tremendously rewarding way to live one's life and to have meaning in your life, which I think we all look for in many ways. There's talk and cynicism about medicine not being as interesting as it used to be. I personally think it's getting more interesting. You know, how to bring all this new technology, artificial intelligence, all of these new things, big data, stem cell science, into the service of human health. And it's a great combination of the art and science. It's the personal touch that we bring as doctors, and that's what we can't lose. It's a great career. I encourage everyone to go into medicine, and if you really want to have a great career, you should just go into surgery. Because we actually get to cure disease. We treat patients in a very intimate and a very immediate way, and there's just nothing more satisfying. I'm a little biased there.
What qualities do you look for in recruiting residents to our surgical training program?
I look for grit, I look for drive, I look for compassion. Mostly I look for a commitment to excellence. I want to train future leaders, whether that be in your community hospital, whether that be in your profession, whether that be in your scientific inquiries. I want people who are going to go out and represent Davis well, represent our profession well, and perform at the highest level.
Can you share your experience of being one of the first women surgeons, especially as one of the first chairwomen in surgery?
Dr. Blaisdell, I think, was an early leader in encouraging women to enter surgery. So it's been a privilege to follow in those footsteps.
What is your fondest memory of your time in Sacramento?
I think it was the first class of graduates when I came here, and I realized that they had probably 5 different department chairs over the course of their training. And so I had the privilege of inviting Dr. Wolfman, Dr. Blaisdell, Dr. Goodnight, Dr. Wisner, who had served as our interim chair, all to be part of their graduation, and that was a very special moment. I didn't realize at the time how rare and historic that was, and I'm so glad we were able to do that.
And now I'd like to turn your attention to what are effectively the pillars of the Department of Surgery, its divisions. Dr. Farmer and I have asked each division chief to prepare a snapshot of their division's history and/or accomplishments. Over the next few moments, I will briefly review these subjective summaries and highlights. They serve to complement the information already provided by the chairpersons in the interviews that you just saw. In their entirety, these division summaries underscore the extraordinary benefits and the breadth, level of accomplishments, and diversity that our divisions contribute to the department's three core missions: clinical service, education, and research. Because there are so many divisions in the Department of Surgery now, and in the interest of time, we will not be able to go into all fine detail on each slide. You can look for the details when it is uploaded to the intranet. Rather, I hope that the wealth of information provided will spark your interest to obtain more information on particular aspects. So I believe that the blue service was the Hickey service. Am I correct, Dr. Goodnight? So in 1978, when Dr. Blaisdell arrived, there were essentially three services: the blue, white, and gold service. Presently, you see we have numerous services. It has been a mission of Dr. Farmer to develop the subspecialty services here at UC Davis. I'll start with the former SGI division. SGI, as many of you recall, used to be the GI surgery division with broad clinical portfolio listed here. SGI was also the basis for the present foregut, metabolic, and general surgery service. I'd like to point out that the leadership of Dr. Wolf and Dr. Ho in bariatrics and gastrointestinal surgery was important to the development of the present foregut division as we know it today. In 2016, the division was restructured under Dr. Ali. Notably, over 35 fellows have been trained over the years. Our colorectal surgery division, First Chief Linda Farkas, has also been extremely busy clinically, and they were very quickly busy, having numerous accomplishments thus far. We welcome you. Trauma, critical care, and acute care surgery has had a large number of highly accomplished division chiefs. As we have all experienced, the division is clinically extremely busy with a large legacy of fellows. Surgical oncology. Complementing the already ample information presented by Dr. Goodnight in the video, this slide lists our surgical trainees who pursued a career in surgical oncology, all having trained at top-notch institutions, 22% in academics. Their high level of academic accomplishment is underscored by the large number of presentations at national meetings and publications in peer-reviewed journals. Perhaps surprising for some, transplant at UC Davis has a long history. The first liver transplant was performed in 1983, capped by the #1 ranking by volume for kidney transplants in the United States in 2016. The cardiothoracic surgery service has excelled both in the clinical and in the research arenas. It has received numerous awards and accolades, and is one of the few integrated CT surgery residency programs in the country. The vascular surgery division has been well represented at the national level, and it is notable for its very comprehensive fellow and resident education, being the first program to begin an independent and integrated program simultaneously. Burn surgery has its origins in a jet crash fire in Sacramento. Currently, the burn service provides exceptional clinical care and has been very prolific in research. 26 clinical fellows and 16 research fellows. Pediatric surgery. The care in pediatric surgery has been provided collaboratively by Sutter and university surgeons. This has provided for an interesting and diverse resident experience. Dr. Marr, the chief at Sutter Pediatric Surgery, who joined their group in 1981, has been a prominent influence for all of us here at UC Davis in pediatric surgery. Recently, the university service received a boost with the arrival of Dr. Farmer and the recruitment of the UC Davis chief, Dr. Hiroshi. Plastic surgery has a colorful history, with Dr. Blaisdell, in this letter from the dean, being appointed as the chairman of the plastic surgery department. He gave that role up within the year to a division of plastic surgery. They have been notable for the very large number of plastic surgery residents that have been trained over the years. And finally, our newest service, the hepatobiliary service and liver transplantation, pending liver transplantation service, was established in 2016 to provide a complement to all hepatobiliary services at UC Davis. We've had 50 years of clinical excellence here at UC Davis. As an example of our clinical excellence, I've selected one of our Professor Emeriti, Dr. Holcroft, as has been mentioned in numerous slides, to speak on his history here at UC Davis. He was the Chief of Vascular Surgery and Trauma, SICU Director, Instructor of Record for the medical students, and Vice Chair of the Department of Surgery.
Can you please tell us about what attracted you to UC Davis when you arrived in 1978?
Dr. Blaisdell. In brief. Yeah, he was charismatic.
Can you please describe your experiences during the early days of the UC Davis Department of Surgery?
Well, it was exciting. We had, Earl had attracted very good residents, and they were just fun to work with. They had a lot of independence. They operated a lot by themselves, particularly at night and on the weekends. But they were willing to work 120 hours a week, and many of them were very good. So that was one of the best things about it.
Can you describe the challenges that the department encountered during the early years?
Lack of facilities. The hospital was tiny. The clinic consisted of two trailers that were attached to one another. That was a clinic for the entire Department of Surgery. So we had some land, and then under one of the early hospital administrators, the university acquired a large amount of land. And then the trauma service began to generate money for the medical school and for the hospital, and then that led to all the buildings that we have now. So that was the single biggest problem back then.
Can you tell us a little bit about the research that you were doing on physiology?
Oh, it varied, but it was all clinically based. So I'd see a problem with a patient, and then I'd have an idea. I'd talk it over with a physiologist, and then sometimes we could put something together and go at it.
Can you tell us a little bit about the development and growth of surgical critical care under your watch?
We had plenty of sick patients, a very heavy load of indigent patients who came in with end-stage disease. We had active trauma. We had a lot of transfers from hospitals in the region, again, mostly indigent patients, but they were sick. Dr. Wolf had a knack for attracting patients that nobody else wanted to take care of in Northern California. Dr. Fry was here. He had a knack for doing the same thing.
UC Davis has also had 50 years of surgical research and innovation. I've selected two Professor Emeriti to represent our surgical research and innovation. I think the person who's doing the next 50 years is going to have a difficult time selecting among the group that are present in this room. But these two mentors of mine were both on the SGI surgery service. Dr. Wolf, one of the leaders in bariatric surgery.
How did you become interested in bariatric surgery?
I was a surgical resident the chief resident in 1972 at St. Louis University, At that time, one of the clinical professors undertook a series of the original operation for severe obesity, a jejunal ileal bypass. I was very interested in surgical nutrition and gut function, and took the lead in determining what the protocol should be. As it turned out, weight loss was successful, but delayed liver failure was a definite problem in some patients. And as it happened, a young woman who had lost more than 100 pounds was admitted with deteriorating liver function. We were unable to turn her liver function around. Liver transplant was not yet available in 1972. So I told the patient we needed to reconnect her operation and that she could expect to regain the weight. She told me that she would not go back. If she dies, she dies, which she did. She died. And soon after that, that scenario played out again, pointing out to me and others that we really hadn't paid much attention to the disease, severe obesity, and its impact on the lives of people in addition to their survival. I've been interested in trying to make bariatric surgery safe and successful ever since.
Can you tell us about the background of the prospective randomized trial of laparoscopic versus open Roux-en-Y gastric bypass?
The history began with the early development of laparoscopic surgery at UC Davis Medical Center by myself and others on the faculty. We are among the first, certainly in the West, to report on laparoscopic surgery, particularly for cholecystectomy. And as that developed, and we were doing bariatric surgery through large abdominal incisions, it was apparent that an effort to include bariatric surgery in the laparoscopic surgery development would be very beneficial. There was almost no bariatric surgery being done by laparoscopic methodology at the time. Many were skeptical that it could be done. It was therefore clear to me that a randomized trial would be the most definitive demonstration regarding this question. We had done very extensive, careful planning, so we assessed every physiologic and surgical parameter we could think of, cardiovascular, pulmonary, renal, etc.
What were the highlights of the results of your trial? Can you also elaborate on the numerous findings and publications on secondary endpoints?
As many as 20 papers were published regarding the various issues relative to the metabolism and physical functioning, physiology resulting from laparoscopic as opposed to open surgery. So that trial was really a breakthrough trial demonstrating the major advantages of laparoscopic bariatric surgery. And it wasn't long after that that laparoscopic methodology took over and literally changed bariatric surgery.
And our last interview is with Charles Fry, who will have his 90th birthday November 15th, the developer of the Fry procedure for chronic pancreatitis.
Can you please describe your development of the local resection of the head of the pancreas and longitudinal pancreaticojejunostomy for chronic pancreatitis, the Fry procedure?
The development of the local resection of the head of the pancreas combined with longitudinal pancreaticojejunostomy was based on the work of many people, and I stood on their shoulders, so to speak. The first procedure, which is pertinent, is the Rochelle-Partington modification of the Pusto procedure, This procedure was performed widely in this country until it was found that in about 30% of cases after 3 to 5 years that the pain relief which occurred initially failed. There were other procedures which had been developed, including the 95% pancreatectomy, which involved the resection all of the pancreas except for a small rim around the inner aspect of the duodenum. This was very successful in relieving pain, and it removed it permanently. However, it created exocrine and endocrine cripples. The result of this procedure, the 95% pancreatectomy, proved to be the first procedure which was the duodenum preserving operation. And it led to a great deal of contention with Hans Bager, who was chairman of surgery in Ulm, Germany. He reported in 1972 on his experience with the modification of his head resection, in which the body and tail of the pancreas was preserved. The body and tail of the pancreas containing most of the islets and exocrine tissue. The only problem with that operation, in my opinion, was that it required dividing the pancreas over the portal superior mesenteric vein, and in chronic pancreatitis, there's a lot of inflammation, and it could be quite a sticky procedure, so that only very skilled people could perform the procedure. The other procedure, which was very effective in relieving pain, was the pancreaticoduodenectomy. That operation, again, was a very extensive operation, and could only be performed by people who were highly skilled, and unfortunately, at that time, it carried quite a mortality, so that was not terribly popular in some quarters. The next development that led to the local resection of the head of the pancreas and pancreaticojejunostomy was my realization, after giving up the 95% pancreatectomy, that and trying the Rochelle-Partington modification, the reports by from the Lay Clinic and Ed Bradley indicating a high incidence of recurrence, got me to thinking that maybe there was a simpler solution to both the Bager procedure and to the pancreaticoduodenectomy. And that was a modification of local resection of the head of the pancreas and combining that with the longitudinal pancreatic osteogeneostomy covered over by a Roux-Y limb. And I reported in 1987 3 such cases. How did this local resection of the head of the pancreas combined with longitudinal pancreatic osteogeneostomy become known as the Fry procedure? Well, who wants to repeat that long litany? That's the only reason that I can think of that my procedure became known as the Fry procedure. If it had been some little simple thing, I don't think my name would have ever gotten attached to it. That I think, was the answer.
So presently, surgical research and innovation has taken an incredible upward trend. And thank you, Tina, for allowing me to use these slides. You can see here that over the last 18 years, we have made remarkable strides. And presently, we're number 6 in the NIH research funding ranking. We've also had 50 years of surgery residency directors and 295 graduates of this general surgery training program. Can I just have those in the room who are graduates of our program raise their hands? I see my friends over there. Nice to see you. Here we have Dr. Pevic with 2 impressionable and bright-eyed interns in 1992. They look a little more comfortable and cozy with Dr. Blaisdell in 1995. We've had exemplary residents over the years. In 1995, we have a tremendous group. I was at mid-level at that time. And then in 2006, I see actually Tom Degoni and Pat Sullivan. Raise your hands. They're in that picture. Yeah, and our dear friends. And our present group of surgical trainees. What a group. We have 50 years of surgery residency coordinators. Kathy Kelly, can you raise your hand for me? She was our Juanita Braxton during my era. And 50 years of surgery instructors of record. We have 50 years of educating UC Davis medical students. And 50 years of working with UC Davis nurses. 50 years of the Department of Surgery staff who have supported us tremendously. And 50 years of caring for UC Davis surgery patients. One of my favorites is in the audience today. He was on this picture. And 50 years of caring that has also been joined by our construction workers. You might have seen the Get Well Soon sign, which I find so endearing. And as Dr. Russell, Dr. Blaisdell's best friend and past executive director of the American College of Surgeons, so beautifully always said, and which was commented on by his daughter at his eulogy. And remember, it's always about the patient. So in memoriam, we remember those who are not with us anymore. Doctors Wolfman, Cohen, Reinsch, Broda, Brofelt, Battistella, Moore, and Newhouse. And now my epilogue. I was recently asked by a resident why I often appear to be enthusiastic and satisfied at work. Well, guess what? I'm not alone. We performed a national survey of general surgeons with nearly 1,000 respondents. And this was published in 2009 in the Journal of the American College of Surgeons. Our multivariate analysis demonstrated that those reporting the least career dissatisfaction, or the most satisfaction, were those working in a university environment. I personally think that this, a priori, perhaps surprising finding, is rooted in the extraordinary richness and depth of our, or for that matter any, academic department in areas of clinical service, education, and research that I have just demonstrated to you. There are 2 hidden gems in the breezeway to this building. One in the southwest corner is Dr. Blaisdell's Civil War collection of books and his Civil War collection of surgical instruments. Please don't miss it. There's also a plaque that hangs near this beautiful art sculpture in the entrance. I've enlarged it for you all to see. The sculpture depicts the differentiation of totipotent stem cells into pluripotent cells. I think this is a metaphor for our general surgery residency and also our surgery department. We're all startups who have become powerhouses in our areas. The sky's the limit. I'd like to give a special thank you. Manny, can you please come? Where are you? There you are. Come here. Manny is the director of photography today. He's the master film editor, and he's also the creator of the logo. This is a shirt from the American Cinematographer, which is the trade journal for the Association of, or the Society of Cinematographers. You are inducted by me to be a new member of the American Society of Cinematographers. Thank you for your over 100 hours. He was accompanied very aptly by our dear Tuan Tran and his new accomplice, Igor Voroshko. I practiced that one. Thank you. And Kim Huntsman, who helped me with the PowerPoint and taught me how to do more of these PowerPoint slick moves. And Umar Waris, who helped me to find Dr. Wolfman's clip from the library. And Christoph Troppmann, my sounding board, my most honest critic, and caretaker of our children. Thank you for 53 years to my Meyer family. They have been my stability and have provided tremendous love through my years. This video project inspired me to videotape my father, who with my mother was a German immigrant to America. He lived the American dream. I encourage you, if I have one recommendation for you today, it's to videotape or audio tape or write down the history of your loved ones and mentors while you still can. And thank you for 13 years to my Troppmann family and my dear Max and Sophia, who saw me working in pajamas all day on Saturday. So let's celebrate the past 50 years. And here's to the next 50 years.
Congratulations to UC Davis.
Congratulations.
Congratulations, UC Davis.
Party's congratulations.
Congratulations, Department of Surgery.
Congratulations to UC Davis Medical School and the UC Davis Department of Surgery on a fabulous 50 years. I look forward to an even better 50 years to come. Congratulations.
Nice job.
Thank you. It's 8:06. Do we have...
I know everybody in this room would have expected nothing less from Kathryn. That was spectacular, really spectacular.
Thank you.
And this is just a hint of things to come because the party is going to be even better. So, I do think we have some time for questions.
Great. Do we have any questions from the audience? Dr. Hundal, of course.
You know, this is going to be a question for Jim or Bill, I think. Around the late 1990s, early 2000, when the Air Force bases in town were closed and the VA managed to get its hands on a old Air Force hospital at Mather. It was, of course, replaced and built, but that disrupted a nice vision that Dr. Blaisdell and you had concerning the VA. There was a time when the VA was going to have its campus actually on the UC Davis campus. And looking back, I can only think that that would have been a very good thing for both institutions. What happened? Was it just the free land, the free money, etc.? It was frankly amazing that Dr. Blaisdell was able to get a VA medical center up here in Northern California. There was a lot of opposition, and after the closure of the Martinez VA, it was something of an afterthought, and the VA that we have today is largely due to Dr. Blaisdell's efforts.
The quick answer is the opportunity to finally get a facility at Mather and not fool around, with more politics. I mean, everyone, and you more than anyone, know the national competition for funds and VA and so forth. Those of us that grew up in my area, Holcroft and so forth, can't imagine a training program without the veterans, without the VA program. I mean, it's been so intimately involved with American surgery in the second half of the 20th century, then in the 21st century. So the opportunity, I mean, we talked about it for years. It was almost unbelievable when we finally truly had that hospital that you had at Mather. And of course, it's been a huge part of the training program, as it was even at Martinez. But it was opportunity, so grab it while you can get it.
I'd like to thank all of you for your exquisite leadership in developing this department. I have a comment and a question. The comment is one of the advantages of being a young department is similar to, say, the NBA. One of the comments of the NBA All-Star Game is you see all the legends of the NBA there at the All-Star Game, and which is unusual. If you think of baseball, no one knew Babe Ruth, no one knew Lou Gehrig, no one knew Ty Cobb. But now you can see Bill Russell, you can see Kareem Abdul-Jabbar, all sort of these famous folks there, and learn from them. And it's the same for our department. All of you are up here, and we can learn from the history of the department by talking to you. The question I have is for Dr. Goodnight. We have the NCI designated comprehensive cancer center, which is a big deal. It's similar to the MD Anderson Center, Memorial Sloan Kettering, and we got our comprehensive designation for Stanford even. But it seems daunting to go from 2 trailers all the way to this comprehensive designation. Did you have did you map out a strategic plan or a strategy to develop this? How do you go from 2 trailers to a comprehensive designation?
Well, I can say facetiously, David, of course we saw it all. But the answer is the 80s started for this medical center with the crisis, and I won't go into that. And actually, the hospital lost its accreditation at one point. And so once we got new leadership and began to solve problems, we were looking for things to go. It's a complex history about how the cancer center came about, but the issue was basically they said, okay, we need radiation oncology. Why don't we build a building for radiation oncology? Frank Loge, who was the hospital director, always thought big, said, hell, let's build a world-class cancer center. So that was then became our goal, and we always said that. We kept telling ourselves, okay, we're going to build a world-class cancer center. Damned if it didn't happen. And the fact that it became an NCI-designated center and a comprehensive center was really due to the leadership of Rafe DeVere White. I got it together clinically, began to put together the money to recruit a lead scientist, and we were able to recruit Sinjin Kung, and that was really key then to the development. The NCI gives the money for the research, but they expect you to build a clinical arena around it. So the recruitment of Sinjin Kung, then the appointment of Rafe DeVere White, based on what we'd already done, they took it and ran with it. And to me, it's just dramatic. Sacramento has so many good features, but it's an unlikely place to have one of 54 comprehensive cancer centers. And it was strictly due to the hard work of so many people and just this steady vision. But it's like I said, like I quoted Judah Fuchman, you can only see as far as your headlights, and you hope then with each subsequent time you do the best you can do with each segment. I think everyone did.
Dr. Farkas?
So you are all wise, or you would not be sitting up there in front of us all. But I think the wisest look retrospectively at their careers and maybe would then share something that they wish they had done differently during their tenure. And so if anyone would be willing to share what that would have been.
Linda, it's a great question that you ask. I was sitting here as I watched the videos of others and thinking of the wonderful things they did. And as I look back, I said, gosh, I wish I'd done more to help at that time always. Life's always a double-edged sword. I mean, the great achievements are always accompanied by complications and problems in life and all the personal things. I mean, nothing's ever straightforward. I just finished the biography of Muhammad Ali, that the great fighter, and it's a tough book to read, just given his life. But I'll have to say, the tears streamed down when they finished the book with him lighting the flame in Atlanta, how it all came together. I mean, it was built on many, many difficulties. And as I look at the videos and so forth, so you can see all the downsides. I remember all the downsides of just people's personal problems, issues, money, et cetera, and I'm thrilled with what was achieved. Life goes on, but then every so often people rise above the standard problems in life and so forth. And so you always look back and say, wish I could have done more.
Go ahead.
Well, I'm going to sidestep by saying I hope I have a few more years to answer before I have to answer the question. So, I think there are exciting things coming. You know, when you talked about the development of the Comprehensive Cancer Center ahead of Stanford and, unlikely to happen in Sacramento, I found myself thinking, I actually think Sacramento is the right place for all of these things to be happening, and especially now. It is the fastest growing city in California. It is the only of all the UCs that have land, which is a huge asset. You know, having lived in a place where all the time the conversation was, there's a building cap. So I think we are really just finishing the first phase of the development of this place. You know, if you look at UCLA and UCSF, they've got 150 years. Stanford's history is in that same category. We're just beginning, and I think that with the growth that's happening, with the fact that we are really the only major medical center that represents inland California sort of at all. I mean, all of our other sister institutions are quite coastal based and very focused that way. And I think there's a tremendous swath of the state of California that we need to serve and beyond. And I think this is truly just the beginning. And there's a lot more room for growth, even on this campus as well as in our region, that make this an incredibly exciting time to transition into the next phase.
Well, I don't have time to tell you about all the mistakes I've made. And sometimes I've learned. There have been times when I've lost my focus. There's no question about that. But I hope that we can maintain our focus on the medical students and on the residents, because ultimately that's where the strength is going to be. And I think that's hard to do, but we are a medical school, and I think that's what we should keep in mind.
Maybe just to add another dimension to the answers, and this is a very personal answer. I think I would have figured out about myself a little bit sooner that I needed to shake it up about every 3 to 5 years. I actually ultimately did figure that out about my career, that I needed to do something off course about every 3 to 5 years or I'd get bored. And I came to that realization maybe about 5 to 10 years later than I would have ideally liked to do. And that's just me. But for some of the folks in the audience, I would say that also might pertain, that if you find yourself kind of stuck, even if you really like what you're doing, if you find yourself kind of stuck, do something different. And actually, this has been a great environment for me to do that. I've been able to do some jobs that aren't in this place, but still work for the university, which has been fantastic.
So I'd like to thank our leaders for your mentorship throughout the years, and to our division chiefs for their contributions, and a warm thank you to our medical students, residents, fellows, and staff, and nurses, of course, who have really made this department a remarkable place to work and to be. So thank you so much for your attention today.